Welcome to our nursing documentation in service. The nursing process is your charting should leave no question in a reader's mind that you continually and carefully assess the resident's condition and monitor his or her progress. The documentation provides legal credibility if documented in timely, accurate, and appropriate. Keys to improving documentation is think first, write second. Document only what you observe. That is only what you can see, touch, smell, or hear. Do not speculate. No need to enter this writer, this nurse, this employee, or I, and your name, because when your signature indicates your involvement. Use the resident's words. I slid out of my wheelchair, but I'm fine. I should have waited, but I went to the bathroom. Or it's a dull ache when I sit too long. Omissions in documentation may suggest that basic care was not provided, physician's order were not followed, residents were not supervised adequately, and special care needs were not addressed. If it was not assessed upon admission, we will own it. Wounds, mushy heels, bruises, weight loss, physician's order, antibiotic medication, abnormal vital signs, and antipsychotic medications. Always just document the facts. Document that is provided in the medical records must be based on objectivity observations, but never on subjectivity conclusions. Communications is document communications with others regarding the resident. Document essential data shared with physician, family members when a resident experiences change in condition. Document all attempts to reach the physician. Do not document in an accusing manner. Always document notifications and referrals, that you notify the social worker about behavior symptoms, you notified a dietitian about a pressure sore, weight loss, or abnormal lab values, and you notify the physician. Falsification and omitting documentations are red flags. Holes in MARS and TARS, inconsistency in documentation, nurses' notes differ from the MedAids documentation, MARS are not consistent with narcotic log, and late entry. If it wasn't charted, it wasn't done. That has been the same forever. What is appropriate nursing documentation? Appropriate documentation provides an adequate reflection of nursing assessments, change in clinical state, care provided, and pertinent patient information to support the multidisciplinary team to deliver great care. Documentation provides evidence of care and an important professional and medical legal requirement of the nursing practice. Why is documentation important in nursing? Good documentation is an important part of improving both patient care and nursing practice. Proper documentation promotes safe patient care, good communication among staff members, and the advancement of nursing profession. How do you doc nursing interventions? Document how you provided care according to the standards of care outlined by the state and facility where you practice. Include nursing interventions. Add the interventions you provided and the patient's response to the treatment, including any patient refusals. If the patient refused treatments, document the incident. Is nursing documentations irresponsible? As nurses, we know that failure to provide timely, accurate documentation is unsafe, irresponsible nursing care. This is true even when we're caring for high acute patients in an understaffed environment. Did you know that medical records might be the only evidence presented in a lawsuit? That is because the patient's medical record is the most powerful legal tool an expert witness used to examine the type of care the patient received from the health care provider. As nurses, we know that failure to provide timely, accurate documentation is unsafe, irresponsible nursing practice. This is true even when we are caring for high acute patients in an understaffed setting. If care was provided that wasn't documented in a timely manner, the failure to document the care could put a patient at risk for getting a double dose of medications, unnecessary treatment, or a discontinuing in medical care. When documenting, don't write illegibly. The judge or jury can interpret messy writing as a reflection of messy practice. Use uncommon abbreviations. Avoid abbreviations that are non-medical and never add texting language in patients' records. Include subjectivity data. For example, refrain from documenting judgments you made about a patient like he is an angry old man, she is irresponsible and rude, or she is a spoiled little brat. Keep the documentations objective. Leave in large sections of time blank. Remember, if it wasn't documented, it wasn't done. Don't add in late entries. Try to squeeze in or add a late entry to the patient's record to look as if it was documented on time. Failure to document a change is extremely important that you document any change in patient family status that occurs during your shift. Never document adverse events. Refraining from documenting the patient's chart that an adverse event reported was completed. Erase or use different colored ink. Don't use different colored ink, erase, or try to cover over an entry. Although most facilities have electronic records, many places still have some handwritten documentation records. It's important that you continue to employ the handwritten standards of proper documentation. When documenting, do use objective data. If a patient refuses medications, document exactly what occurred in the chart. For example, you could document the following. After giving the patient his oral medication, he threw the medication on the floor and said, "I refuse to take this poison." Include the following: date, time, your title, and your full name with your signature in every entry. Follow the standard of care. Document how you provided care according to the standards of care outlined by the state and facility where you practice. Include nursing interventions. Add the interventions you provide and the patient's response to the treatment. Include any patient refusal. If patient refuses treatment, document the incident. Include the patient's verbal and nonverbal response, such as using as much objectivity detail as possible. Include follow-up care. Document how you followed up a medical situation with the appropriate patient care. For example, if the patient's status changed and you notify the physician, document the change in the patient's data and that you notify the physician. Being sure to include the changes the physician made and the patient's response to those changes. Make documentation a continuing, ongoing process. Do not leave large space of time in the patient's chart. Although you may know that you were observing the patient, the court only has the patient's medical record to go by, and a blank area in the patient's chart can be interpreted as a breach of duty. Documenting the discharge teaching. Include in the chart how the patient demonstrated an understanding of the discharge plan. Include where care you delegated. Document what you delegated to other staff members and when that care was provided. This demonstrates that you made sure the duties you delegated to the staff were provided to the patient in a timely manner. Chart according to your 5 senses. Include terms like, I palpated a pea-sized lump. I observed a yellow tint to the skin. Skin was hot to touch. Crackles were heard in the lower lungs, or urine was dark amber in color with a strong odor if in the patient's chart. Include any objectives. Document in the patient's chart any treatment plans or interventions that you objected to and how the situation was handled. Good documentation is an important part of improving both patient care and nursing practice. Proper documentation promotes safe patient care, good communications among staff members, and the advancements of nursing profession. Do use objective measures 3 times per hour, once weekly. Do reflect skilled services, assessments, education, teaching, evaluating effectiveness or modification. Document how therapy is impacting functions on the unit. Document recommendation training received by therapy. Document what you saw, heard, felt, and smelled. Don't use vague terms frequently or occasionally. Don't use non-skilled terms, observation, monitoring, supervised, routine, or unchanged. Don't use statements reflecting no change or benefit from therapy. Don't document conflicting entries. For example, therapy documents trained on use of sideboard, but nursing continues to transfer with to assist. Don't rely on secondhand reports. Along with our skill charting, we also need to make a progress note. I know that is a lot, but a lot of this has to do with our payments and insurance. Every week we have to update the insurance companies, and they're going to tell us if they're going to continue to pay for their stay there at Homes or at Brookside. So here is some of the things. Why is the patient here? Were they here from a broken hip? You have to chart that they're receiving therapy, that they walked, or if they're in any kind of pain. What is preventing the resident from going home right now? Are they still able to dress or not dress? Can they take a shower by themselves? Can they go up and down stairs? All this has to be documented. And this is our rugs to support, and this is what I'm talking about with insurance and stuff. So documentation is very important. The rugs in healthcare, which it does stand for, is a patient classification system for nursing home patients used by the federal government to determine reimbursement levels for skilled nursing home facilities. This system categorizes residents into a payment group based upon their care and resource needs. There are 7 major RUG categories: rehabilitation, extensive services, special care, clinically complex, impaired cognition, behavior problems, and reduced physical function. What is false documentation in nursing? The falsification of information is a serious matter, especially in healthcare. Chart falsification comes in many forms. A nurse might do an early documentation by signing off early on the medication chart, indicating that she had given the medication before she actually did. Falsifying of documentation is against the legal parameters. Nevertheless, many nurses take it as a light matter and overlook the serious consequences that they will have to face due to this illegal omission. If they are convicted to the felony, they will be responsible for the fines, lose their license of practice, and face a jail time. I know we've had a couple of nurses chart all their treatments and said, well, I wrote them down and I mark them off as I go. If state walked in and seen that you did the treatment and they go look, because you documented you did it, and it's dated for the day before, that is false documentation because it has not been done. Death must have all information included in time of expired, time family was notified, who was notified, that the coroner was notified, time hospice was notified, and time the body left the mortician or the mortuary, and was family present. Second check charts must be completed, and if they do not absolutely have time, new admit charts must be second checked on night shift, and this is non-negotiable. They must note each page of the chart indicating that they did their second chart check. If there is an entry error and they didn't second chart check the new admit, the nurse that should have done the second chart will also be written up. We had an incident with our charting. This was it. She came into our facility She was there for over 3 hours. Nobody charted that she even arrived in the facility. Nobody did her vitals. No assessments were done. These were the notes that came in late. After the fact, the resident did pass. So when we have to go in and do the discharge summary, we have no idea what mortician she went to. We had no idea if family was there, hospice, if anything got sent to the mortuary with her. Nothing. This is what we were left with. And we actually had to call the nurses to come back to do this. This is unacceptable charting. So here is incorrect. Resident expired at 1910. Correct. All vitals ceased at 1910 with daughter Karen present at bedside. RN verified. Contacted Dr. John Doe. Called at 1915 and received orders to call coroner. No autopsy. Okay to release body to the mortician, and doctor will sign the death certificate. Hospice was contacted at 1950. Coroner contacted at 1920. Body released to Roper and Son at 1930. Daughter took personal belongings with her. If family's not at bedside, you must call the family right away, and you must verify the mortician or mortuary with them over the phone. Do not wait for the hospice nurse to arrive to do this work for you. Admission note, incorrect. Dale arrived to the facility. He's resting quietly in his room. He was admitted with pneumonia, alert and orientated ×3. The correct way of charting is Dale was admitted from Brian East versus Facility Ban at 12:15. Dale is admitted for ammonia and is currently on IV antibiotics, IV to right arm. Dale is alert and orientated ×4. Transfers from wheelchair to bed with 1 assist. Dale wears glasses and has hearing aids, denies any swallowing or chewing problems, and has a partial upper denture. Takes his meds whole, regular diet, breathing quiet, non-labored, left lower lobes have rails, all other lung fields are clear. Wears 2 liters of oxygen versus nasal cannula, abdominal soft with no distension noted, bowel sounds active ×4, states his last VM was 11/4/2020, continent bowel and bladder, wears disposable briefs, BLE has 2+ pitting edema, pedal pulse is strong, Dale wears knee-high TED hose, wounds to right gluteal cleft is open and 50% sluggish is covered, wound measures 5 centimeters by 3 by 0. Surrounding skin is pink and intact. Dale denies pain, call light within reach, and bed in low position. Every new admit, skilled and non-skilled, has to be charted on in progress notes for 72 hours along with their skilled charting. Skin must be thoroughly looked over upon admission, and any wounds or breakdown must be measured and documented. If not, it becomes a facility-acquired wound if you do not claim it on admission. This is extremely important. You must note the pages of the transfer from the hospital when checking a chart with your name, date, and the words noted at the bottom of each page of the transfer packet, with orders verifying that you have received them and they are in the computer correctly. Falls. Incorrect. Doris fell this shift. CNA did not have her call light within reach and had it attached to a recliner, causing her fall. Do not ever throw your coworkers under the bus in your charting for the world to see. If there is concern, tell your manager. Correct. At 17:20, this nurse went into Doris's room and she was found laying next to her bed with her legs extended out in front of her. Doris denies hitting her head, but neural checks were initiated at the incident was unwitnessed. Doris states that she was trying to get to the bathroom. Range of motion within normal limits. Denies pain. Doris was too assisted to the wheelchair and transferred to the bathroom. Reminded Doris to use her call light and the risk for falling when she transfers. No injuries noted. Son Bob notified at 17:35 of incident. Dr. John Doe notified of fall. If there are no injuries, you do not need to call the manager after hours, as she will see it once you enter it into the risk management. If you call Mobile X or send to